Bacterial infections of the central nervous system. Before the modern antimicrobial era, non-viral infections of the central nervous system were almost universally fatal. Advances in cerebrospinal fluid diagnostics, neuroimaging, antimicrobial therapy have markedly improved the outcomes. Despite these developments, CNS infections remain medical emergencies because delayed diagnosis and treatment. Early recognition of CNS infections is therefore essential. Important predisposing factors for the CNS infections are geographical residence and travel history, occupational and recreational exposures, recent sinusitis or otitis media, chronic medical illnesses and vaccination history. Immune status of the patient. Immunocompromised individuals are susceptible not only to common pathogens but also to opportunistic organisms, which are rarely seen in immunocompetitive hosts. Clinical manifestations may also be subtle because of impaired inflammation. This consideration is particularly important in fungal and parasitic infections. Bacterial infections of the CNS. CNS infections occur when pathogenic bacteria invade the nervous system through nasopharyngeal colonization and invasion, contaminated food ingestion, systemic bloodstream infection, neurosurgical procedures, contiguous spread from nearby sites like sinusitis, mastoiditis, otitis media. Host immune defects such as hypogammaglobulinemia, T cell dysfunction, complement deficiencies increase the susceptibility for infection. Meningitis classification. Bacterial meningitis is broadly classified into acute and chronic. Etiology of acute bacterial meningitis. The most common causes of community-acquired acute bacterial meningitis are Streptococcus pneumoniae, Neisseria meningitis. Other important causes include Listeria monocytogenes, Haemophilus influenza, and anaerobes, especially in mastoiditis or sinusitis-associated infection. Pathogenesis. Streptococcus pneumonia and Neisseria meningitis colonize nasopharyngeal mucosa and subsequently invade the bloodstream and the meninges. Listeria monocytogenes is typically acquired through contaminated food. Vaccination and epidemiology. Haemophilus influenza B vaccine. The introduction of HIV vaccine has reduced Haemophilus influenza meningitis in children. Pneumococcal vaccine. It has reduced the otitis media and secondary meningitis incidence. Meningococcal vaccines. Tetravalent vaccines cover serogroups like A, C, W135 and Y, and separate meningococcal B vaccine targets the serogroup B. Listeria meningitis. Risk factors. Listeria monocytogenes. Meningitis commonly occurs in age more than 50 years, diabetes mellitus, chronic illnesses, malignancies, and immunosuppression. Chronic bacterial meningitis. The common causes. The leading worldwide cause is Mycobacterium tuberculosis. Other important organisms include Treponema pallidum, non-tuberculous mycobacteria, Brucella, Leptospira, Francisella, Actinomyces, Coxiella, Ehrlichia, Anaplasma. Clinical presentation of acute bacterial meningitis. The classical triad is fever, headache, and neck stiffness, also called meningismus. Additional features are altered mental status, progressive decline in consciousness, and petechial rash, especially with Neisseria meningitis, and seizures. Symptom frequencies: headache being most common, 87%, neck stiffness 83%, fever 77%, altered mental status 69%. Most patients present with at least two of these symptoms. Chronic bacterial meningitis. Symptoms are insidious headache, mild neck stiffness, low-grade fever, and night sweats. Focal neurological deficits may later develop, particularly like cranial nerve palsies, stroke syndromes due to meningovasculitis. Neurosyphilis. The presentation is chronic meningitis, meningovasculitis, cranial neuropathy, or stroke-like syndromes. Less commonly presents as stapes dorsalis and dementia. Diagnosis. Lumbar puncture is essential for diagnosis unless contraindication exists. When to perform neuroimaging before lumbar puncture. Like neuroimaging like CT brain should be done before lumbar puncture in patients who have altered consciousness, focal neurological deficits, new onset seizures, papilledema, raised intracranial pressure, immunocompromised state. Streptococcus pneumoniae, the common bacterial pathogen causing meningitis, can be identified by using combination of blood and CSF investigations. Streptococcus pneumoniae is diagnosed by blood culture, while CSF examinations typically show gram-positive diplococci in pairs on gram staining, along with positive culture. Listeria monocytogenes is also identified through blood culture. CSF findings reveal gram-positive rod with supportive culture and molecular panel testing. Bacterial meningitis is commonly detected by blood culture, whereas CSF gram stain demonstrates gram-negative diplococci. Haemophilus influenza type B is diagnosed through culture methods and CSF usually shows gram-negative coccobacilli. Mycobacterium tuberculosis, it requires larger CSF samples, usually 20 to 30 ml, for acid-fast bacilli staining, culture, and PCR testing because of low organism burden. Spirochetal and zoonotic infections. Certain spirochetal and zoonotic infections such as Treponema pallidum, Borrelia species, Leptospira species, Brucella species, and Coxiella burnetii rely more heavily on serological tests including VDRL, ELISA, Western blot, MAT, antibody index studies, while some may require prolonged culture in special media due to their fastidious growth characteristic. The role of imaging. CT scan, it is useful for detecting mass lesions, excluding cerebral edema, herniation risk, identifying the abscess or tumor. MRI brain with contrast is preferred in chronic meningitis because of superior sensitivity. Importance of early antibiotics. If imaging is needed before LP, then you should obtain blood cultures immediately, start empirical antibiotics without a delay. Delay in antibiotic administration increases the mortality and morbidity. CSF findings in bacterial meningitis. The typical CSF profile: neutrophilic pleocytosis, elevated protein, low glucose, CSF serum glucose ratio less than 0.3. CSF findings in viral meningitis will be typically lymphocytic pleocytosis, mildly elevated proteins, and normal glucose. Microbiological diagnosis. Gold standard is CSF gram stain, CSF culture, and culture may require 48 hours to 72 hours. Blood culture may also identify the organism. PCR based diagnosis. Rapid PCR assays can detect several pathogens including Streptococcus pneumoniae, Neisseria meningitis, Haemophilus influenza, Listeria monocytogenes, Escherichia coli, Streptococcus agalactiaceae. Advantages are rapid turnaround and higher sensitivity. Limitations are limited availability and no antibiotic sensitivity data. Diagnosis of chronic meningitis. The important principles to be followed are: 1. Repeated high volume CSF sampling is necessary. Sampling near radiological abnormality can improve the yield. MRI with contrast is preferred imaging modality. Tuberculous meningitis. The typical CSF findings: mononuclear pleocytosis, elevated protein, mildly reduced glucose. Diagnostic tests: acid-fast bacilli smear, culture, PCR for Mycobacterium tuberculosis. Diagnosis of neurosyphilis. Diagnostic criteria: you should have either positive CSF VDRL or CSF pleocytosis with elevated protein, along with positive serum serology like RPR, VDRL, FTA, ABS, or TPPA. Management of empirical antibiotic therapy. Initial treatment depends on patient age, immune status, predisposing risk factor, likely organism. Therapy is later modified according to culture sensitivity results. Empirical and specific antibiotics for bacterial infections of the central nervous system. Disease entity, organism and antibiotics. First, acute bacterial meningitis. When age is less than 50 and there is no risk factor for listeria, streptococcus pneumoniae and Neisseria meningitis are common. So, antibiotics are vancomycin with ceftriaxone or cefotaxime or cefepime. If acute bacterial meningitis with age more than 50 and or has a risk factor for listeria, so the organism in additional is Listeria monocytogenes. So the antibiotic in addition is ampicillin. If there is sinusitis, mastoiditis or otitis predisposing causing meningitis, then along with the above mentioned organisms, anaerobes can be the cause. So antibiotics is as mentioned previously along with metronidazole. Brain abscess. Organism is likely Staphylococcus aureus, aerobic and anaerobic streptococci, oral and gastrointestinal flora, including bacteroides. Antibiotic is vancomycin, ceftriaxone or cefotaxime or cefepime with metronidazole. Brain abscess can also be because of nocardia. Then antibiotic would be trimethoprim sulfamethoxazole. For spinal epidural abscess, organism is staphylococcal species, streptococcal species, enteric gram-negative bacilli. Antibiotics are vancomycin with ceftriaxone, cefotaxime or cefepime. Chronic meningitis, organism is Mycobacterium tuberculosis. Drug therapy involves isoniazid, rifampicin, ethambutol, pyrazinamide. Neurosyphilis, organism is Treponema pallidum. Treatment is intravenous aqueous crystalline penicillin G. Central nervous system doses for commonly used antibiotics. Vancomycin 40 to 60 mg per kg per day divided into 8 or 12-hour dosing. Ceftriaxone 2 gram every 12 hours. Cefepime 2 gram every 8 hours. Cefotaxime 2 gram every 4 to 6 hours. Ampicillin 2 gram every 4th hour. Metronidazole 500 mg every 6th hour. Aqueous penicillin G 18 to 24 million units per day. Dexamethasone therapy benefits. Adjunctive dexamethasone helps reduce mortality, reduce neurological complications, especially beneficial in pneumococcal meningitis. Timing, it should be administered just before or along with first antibiotic dose. Management of chronic bacterial meningitis. The treatment depends on specific organism, antibiotic susceptibility, duration of need of therapy, need for corticosteroids. The therapy is individualized according to the etiology. Key take-home points. CNS bacterial infections are neurological emergencies. Early recognition and treatment are critical. Streptococcus pneumoniae and Neisseria meningitis are the commonest causes of acute bacterial meningitis. Lumbar puncture is the cornerstone for diagnosis. CT brain is required before lumbar puncture in selected patients only. Start empirical antibiotic immediately if meningitis is suspected. Dexamethasone improves outcome, especially in pneumococcal meningitis. Chronic meningitis requires extensive evaluation for tuberculosis, neurosyphilis, and other atypical infections.